Hello, everyone, and welcome to Encopresis Essentials, What Every Clinician Needs to Know, hosted by us, Amy O'Malley and Kim Wesley. We are respectively from Good Beginnings and GI Psychology, and we can't wait to introduce ourselves and tell you a little bit more. I will start with myself. My name is Amy O'Malley. I'm a physical therapist. I was trained in the Chicagoland area. So my master's in PT is from Midwestern University. And then my clinical doctorate is from University of Montana. Later on, I have worked before at Laura Beta Children's Hospital in Chicago, and then a smaller practice in Tennessee before I came to Good Beginnings in 2004, going on 20 years as of today. And I am their current director of programming, as well as the head bowel and bladder therapist, and I see patients and do a lot of admin and programming work. I became a board certified pediatric clinical specialist via the American Board of Physical Therapy Specialists in 2014. And to add on a little more, I am a teaching assistant for Mary Massery with her work, as well as Dawn Sandel-Cheedy, who is in charge of all the pediatric bowel and bladder courses for therapy and support personnel in the country and kind of around the world. So I'm really excited to be here to talk to you about this. And with me is my colleague.
Hi, I'm Dr. Kim Wesley. I'm a clinical psychologist with the GI psychology team. A little bit about me. So I completed my undergraduate work in psychology at the University of Virginia before going up to Philadelphia, Pennsylvania to earn my doctorate in clinical psychology at LaSalle University. While there, I had a concentration in health psychology and racked up some experience in academic medical centers in practicum and on my internship as well, leading to my postdoctoral fellowship at St. Jude Children's Research Hospital down in Memphis. After fellowship, I went to the Children's Hospital of Philadelphia for about 4 years and worked within their division of gastroenterology, hepatology, and nutrition. Then I relocated to Central Virginia, where I worked for Central Medical Group from 2019 to 2023. And last summer, just about 1 year ago, I joined the team at GI Psychology.
Wow. Do you want to take everyone through today's objectives?
I would love to. So today we're going to talk first about what is encopresis and how do we typically go about treating it. We'll talk about some of the challenges, some of the stigma, the misconceptions, and adverse effects of treatment as well. Amy is going to take us through what typical function, what constipation, encopresis, and the rare reflex are. We'll talk about the state of the region regarding treatment in the Northern Virginia, DC metro area. We'll talk about how our teams are working together to improve the state of the region and offer different treatment packages to our children and families in the area. And then we'll also talk about common referral questions and how you as a provider can help.
All right. Kim, why don't you take us through the next few slides about what encopresis is and what it is not?
Absolutely. So encopresis is when stool leaks out of the body onto clothing or whatever else happens to be there, often without any awareness of the child. We typically see encopresis with constipation, where the liquid stool is kind of sneaky and works its way around the harder stool. And over time, the children will lose sensation, they'll lose control, and they may experience those soiling episodes, again, outside of their own awareness, as they don't even feel it happening. Their colon has become stretched and that stool leaks out. There are a few different names for encopresis. We sometimes might refer to it as fecal incontinence. You might also hear it referred to as soiling. It's important to know that these episodes are different from just children who haven't mastered toilet training or achieved full control over their bowel. We reserve encopresis for when a child is past the developmental age of 4 and has successfully completed toilet training. We really do place an emphasis on the fact that this is involuntary, and Amy will talk to us in a little bit about what the rare reflex is. And what encopresis is not. Oftentimes we have individuals who may think that encopresis is this act of defiance, that it's happening through the conscious choice and control of a child to misbehave or to get back at somebody, but that is not actually true. Encopresis is not the child's fault. It's not an active choice. And it's also not always due to trauma or abuse. There are certainly cases where an individual may start to demonstrate encopresis in response to trauma or if they're in an abusive situation, but that's not always the case. And it's also not happening despite having a clean colon.
Hey, well, then I'll take over and take you through the joy of typical bowel function and talking about poop. Um, Welcome to our daily lives. But it's a really great time to just review typical bowel function since we have a variety of different practitioners who are on here. And some of you may know this intimately, and some of this may not be the primary area of your practice. But as we all learned in elementary school science, you take in food through the mouth. Right. And so we're going to follow our nice little schematic here. Food goes in the mouth where it is mechanically broken down via chewing into very small pieces, small enough that it can slide down the esophagus and into the big pouch that is the stomach. The stomach's job is to break that down into chemical blocks that we can utilize. And then it leaves the stomach and it goes into the small intestine. And those miles and miles of small intestine take out all the nutrients that our body needs, leaving all of the waste product that we don't. And then the waste product then moves over to the what will be the left side of your screen, but the right side of our bodies, to the large colon just over the appendix, starting at the cecum. And then throughout this travel along what is the green colon, it will have to move all the way around all those curves, and the large intestine takes out enough of the water and dries it out so that we're looking for what we call a perfect poop. And if you look to the right of your screen, you'll see the Bristol stool scale. This is our favorite version from Australia. And number 4 is the one that we're looking for. It's one nice, solid, smooth, slick piece, often described as looking like a sausage, which is what your colon really wants, for it to slide through that smooth muscle tissue, navigate those corners and that big 120-degree curve down by where it turns blue to go into the sigmoid colon and into the rectum. As you'll see from the other areas on the chart, there can be drier poops or stools that go into dry constipation, and then there are the wetter stools that have a hard time sticking together all the way through diarrhea. There are 4 phases of defecation as identified by Palin in 2002, and nobody's needed to update it yet. One is that stool moves into the rectum all the way down at the end. After stool is in the rectum, the individual would get an awareness of urge with enough time to manage to get to an appropriate toileting situation. Number 3 is a very nice and smooth, ideally, expulsion of the stool going out through the anus. And then number 4 is a very clean termination where it's done and over and it's time to clean up. That's what we all are hoping for, or what we really want to expect. There are some things that govern how this works, and this rare reflex is really important to understand. It's called the recto-anal inhibiting reflex, with references for you to talk about. And what it is the automatic reflex relaxation of the IAS, stands for internal anal sphincter, and the EAS down below is the external anal sphincter. And the IAS, the internal sphincter, is really the gateway to determining what's coming through to exit and what state of matter that it's in. So we all know our states of matter from science can be solid, liquid, or gas. And so for bowel, that stool, gas is toots, or liquid would be diarrhea. Okay, so if when the stool comes along and comes up to the pair of sphincters and tests it out, something, I tell the kids, it knocks on the door, and if it is a solid stool, we have enough higher cortical function that can allow us to activate the pelvic floor, have a little bit of an inhibitory effect to the tubing to allow time to reach the toilet, reset, and go. If it is gas, otherwise known as toots, the stimulus of the gas alone allows the external sphincter to allow the gas to leave, but we should have enough resting tension in the musculature and in the tissue that it will hold the solid stool in. If it is liquid, this is where it gets tricky. If we think about it, liquid stool often equals diarrhea, and diarrhea often equals an infectious agent or something that shouldn't be in the body. We all have perceived this when we've had the stomach flu or something similar. And the body is programmed to immediately release liquid if it presents itself to the internal anal sphincter. It's because it's perceived as toxic or dangerous. And it's a pre-programmed reflex in your body. There's no higher level cortical functioning that can override it, which is why sometimes the diarrhea commercials you see on TV are funny, but true, because there's only so much you can do before your body will take care of itself to protect it. Failure is automatic and doesn't have voluntary control. And I really need people to keep that in mind if this is something you're not familiar with. So if we go to the next slide, we're going to look at how this works in our kids, right? So we've got just the large intestine on its own, and we've got the large intestine, and we've got multiple bowels in there. And we've got one big constipated poop with a new bowel coming through. And this is what happens to our kids over time. As the unreleased stool that couldn't exit the rectum stays in there, it stretches out the tissue and the stool hardens, becomes very hard and dry and brickly. And there's even spaces in between the dry pieces where something else could fill the space. The soft tissue of the colon itself stretches, but the sphincters that control the in and out and the propulsive force also stretch, and they have less resting tension to help push anything that presents itself. But we don't stop eating. Most of the kids, the severe percentage of the kids, don't stop eating as they're not supposed to. So more stool is constantly being made. And because you need the entire large colon to dry out the poop into a perfect one that we want, there's not enough space for it. And what happens is you have wet poop behind the dry poop. So you've got hard stool blocking the gate, but the liquid stool can find a way around because the body is really ready to let that out. It can leak around the sides and it fills in the cracks of the dry poop and lets it out. And as soon as the internal anal sphincter notes it, it opens it up. And whatever can come out will come out. So sometimes it's a leak if it's just liquid. Sometimes it's a smear if it manages to pull some of the dryness with it. And this will just continue to increase while there is a blockage. And one of the things that the literature is really starting to reflect is how frustrating it is to monitor this, because 70% of children who have a daily bowel movement of our perfect Bristol stool scale 4 can also have residual stool in the colon and have large rectal diameters that set off the entire system. So Kim, why don't you take us through the state of the region, how we're typically managing this?
Sure. So oftentimes when families are experiencing these difficulties like Amy just described, the first line of treatment is to go to the pediatrician. The pediatrician may or may not make a referral to a GI specialist if there's one available. But before leaving the pediatrician's office, typically there's a conversation about medication support that might be available. This usually looks like a laxative. So there are different types of laxatives. We have what are called stool softeners, which will pull liquid back into those hard stools in the colon to try to soften them up and make them easier to expel. We also have what are called stimulant laxatives, which help the body to expel those stool. What we typically see families walking out of the pediatrician's office with is more of that stool softener type of laxative, though we do see a combination of both at other times. What happens next is that families will typically see that while the laxatives are maybe getting a little bit more of that stool out or making those stools a little bit softer, sometimes it's just not enough. That laxative support is not successful to get the encopresis under control or to get on a more consistent bowel movement schedule. So a lot of these families will find us at that point. They might not have seen a urologist, they might not have seen a gastroenterologist at that point. And even if they have, oftentimes we're hearing that families are having virtual appointments, which means that there's no physical examination for this child. We don't know how much stool is in the body. There's no x-ray or imaging to see how much retention there's been, or even if there's that enlargement of the colon, how stretched out it may be. So here's where we are now. As far as we are aware, treatment options are fairly limited in the Delaware, DC, Maryland, and Virginia area, and West Virginia as well. Our East Coast is just, missing, or Central East Coast is missing these treatment options. As far as the DMV area goes, we know that we have Good Beginnings that offers both PT and OT in their bowel and bladder program. And as far as we're aware, there's only one other outpatient clinic in the area through the Wish Clinic that offers these services. We honestly don't know how many psychology practices and practitioners are in the area with this specific training. We do know that there are some trained professionals embedded within academic medical centers, but as far as outpatient or private practice, we really don't know who's available, who's been properly trained. And even if there are psychologists and mental health professionals available, we don't know who they are, so we can't connect with them. So essentially, the long story short, these kids need our help, but there's just not enough help to offer.
Well summarized. We'd love to take you through some case examples because when we first meet with physicians, the first time who are getting to know us, they're so curious and wonderfully engaged on how can we help? And we realize that some of what we can do to help your outcomes be more effective and more timely, you just don't know yet. So let us have some case examples to show you. I'll start with on the therapy side, the physical therapy side. We have two kiddos. The first one is Lucas, name's changed for privacy, and he is a 6-year-old boy with chronic encopresis after previous cleanouts and maintenance therapy. During his evaluation, he presented with postural deviations, trunk, abdominal, and pelvic floor muscle challenges, not only muscle weakness, but impaired motor planning, as well as impaired interoception related to defecation. And for those who that might be a new term, interoception is the word that describes how our body monitors the things that are automatic. So our interoceptive system is part of our sensory nervous system, and it tells you if you're hungry, or if you're cold, or if you're thirsty, or if you're tired, or if you have to go to the bathroom. But you don't have to stop and do a check-in about it. You don't stop and say, this is my time. I'm going to do a double check if I have to go to the bathroom. Your body naturally lets you know. And after there's a disruption in the physiology, the interoception is already impaired. The interoception can also be impaired because the child has developmental challenges. So we can look at it from both ends. For Lucas, his parents were struggling to engage him with the exercises, taking the medicine, and all behavioral recommendations. Parents were struggling with understanding what was intentional, what was not intentional, and were frequently blaming him for not trying. And it took 1 year of failure after maintenance therapy before the GI had learned about us and referred him over. That's one example of a kiddo. The second example is Sophie. She's a 3-year-old girl who had withheld bowels for over a year, had an early incident with toilet training where something plopped and splashed her, and it just scared her to death. And she was not going to engage. Wonderful little girl. And she was previously admitted to hospital, and she is my winner right now. She withheld for 48 hours through 4 full enemas before her system finally caved and let it out. Her parents were at their wits' end. The laxatives were not successful. Behaviorally, they didn't know how to engage a 3-year-old. And at this point, parents had reached out for counseling to help them survive what was really impacting their family. And again, what had happened in this area is that both families had been only offered medical laxative support, but they also needed mental health support. If nothing else, with Lucas, we needed help with behavioral engagement. And while PTs and OTs are trained in a little bit of that, when it goes beyond our general scope, we really appreciate having professionals to guide us. And then with Sophie as well, her parents needed someone to help them. Those are some of my examples. Go ahead, Kim.
And I have 2 very similar examples, names also changed for privacy. First, we'll talk about Mark. He was 6 years old and having these accidents both at home and at school for about 6 months prior to intake with mental health. And his caregivers were very much blaming him for what was going on. And because they thought it was all his fault, they took a very punitive approach to treatment. Anytime that he would soil at home or have encopresis at school, they would often remove privileges. He was not allowed to use screens. He would lose dessert or other special activities. Even extracurricular activities were removed because, again, his parents essentially believed he had control over this and he was doing this to act out or be defiant. What they were not aware of, his parents weren't aware of any of the physiology that we have already covered, that he essentially was unable to feel anything that was happening as it was happening. Mark even became what we would call nose blind, where he was just so accustomed to the stool having leaked that he couldn't even smell it anymore. It was completely out of his awareness, and his caregivers just had a really hard time understanding that, which was a barrier to implementing behavioral interventions that we were trying to work on, because that basic physiological understanding was just lacking at the beginning of treatment. Next, we have Rose, who's very similar to the case just described by Amy as well, where we have a 5-year-old who experienced some pretty unpleasant bowel movements, which led to avoidance and withholding. She had actually had maybe a stomach bug or food poisoning. Something happened where she had some pretty severe diarrhea, developed a bit of a rash, and because of that, created this association that having a bowel movement is painful and it's going to hurt to wipe. So it's just easier to not poop at all. And then that whole cycle of withholding and constipation began. And so here we have, though, the family was very much on board with the medication, the recommendations by their provider. And within just a few weeks of Miralax and scheduled toilet sitting, her constipation seemed to improve pretty drastically. She was having more frequent bowel movements. She wasn't scared anymore because those poops didn't hurt anymore, and everything seemed to be going really well. And so after about 6 weeks, the family stopped doing their scheduled toilet sits and push practice and medications. And because her colon was still so stretched, it wasn't long after the removal of those supports that the constipation and encopresis came back, full force, and we were right back to where we started. So something that both of these cases, and it's very, very common among families who come to see us at GI Psychology, was this lack of understanding about the physiology of constipation, how it's outside of control of the child, how after a clean out, we still need to be vigilant because it can take up to a year for that colon that's been stretched out to shrink back to its normal size. And so that lack of the understanding of physiology and the appropriate treatments really did adversely affect treatment for these children. And that's where good beginnings can be so helpful and so important.
And back at you, Kim. And so the good news is there is so much help available within our disciplines, and we pair really well with the medical model, like we do any other child who's having a medical issue, which is what this is, a medical issue during developmental years that also has cognitive, mental health, behavioral side effects that need to be addressed as well. So we offer at Good Beginnings, and just in case I forget to say later, we have 2 offices in the DMV area, in Falls Church and in Herndon. Right now, our bowel and bladder services for PT are centered in the Falls Church office, just because that's all I can handle right now. There's not enough space in office for me to go to, but we are expanding the OT part of our support to both offices. So I just wanted to make sure that that's clear. But during physical therapy, what we do is what we do for everyone, which is an evaluation and treatment of the systems that we focus on. So we call those cardiopulmonary, neuromuscular, musculoskeletal, and integumentary systems. We are looking at skin and tissue mechanics. We are looking at how your breathing and your posture work with your musculoskeletal system and your nerve function, and all of those things, along with your developmental age, because Good Beginnings is developmental specialists, to see how that's affecting your bowel and bladder function. We also do a screening for the regulation and sensory system to determine interoception dysfunction or higher level regulation issues that also need to be addressed. We see a lot of kids on the autism spectrum that have pretty severe ADHD, things like that, and their systems are already impaired before we even get to the toileting part of it. And so we'll screen for that first and determine what's necessary. What we provide is, under what Kim and I both provide under standard urotherapy, all the education, the really taking them through all the systems that they need to understand, helping with water and hydration and food and nutrition, and, more of the basic stuff of monitoring and giving recommendations. But we also do skilled intervention, as we would do for any other child, and give education in a play-based, developmentally appropriate environment, as well as refer and coordinate with our external specialists, being the GIs, the urologies, our mental health team, pediatricians. I'll give you some more examples later. Occupational therapy will also provide Traditional OT is abbreviated for regulation and engagement, and we typically reserve that for the kids who are not able to participate in PT. We understand that there is a problem, and sometimes kids come in and the bowel system is really impaired, but if they have some significant regulation and behavior issues, they're not going to be able to do the work for it, but we don't just say no. Then we start you with OT to get you prepared, and we actually can coordinate while you're working through that until you can do the full program. And then as a transition out of the physical things, like we like to say that PT clears the physiology. Once the physiology is really doing well, we transfer to the interoception curriculum written by Kelly Mahler, who's the leading OT interoception researcher in the world. And we take them through that to retrain them to relearn their signaling in a more specific context, which is really, really effective. We begin with in-person services. We do offer some virtual follow-up appointments, case-by-case basis, because at this point, we have families coming in from 2 to 3 hours away. And then there are just, with COVID and things like that, we had to make accommodation for when people were on quarantines and things like that. So we prefer in-person, but we do allow some virtual follow-up, and the therapist will help decide that with family. So how do we do what we do? Just like any other PT, we do exercise. People love hearing about how much we're going to exercise. But anyone who does bowel and bladder therapy for littles has taken significant advanced training in the GI/colon/bowel and bladder mechanics, all the medical and basic functions that happen, and then all the muscle strengthening and exercises and motor retraining specific to that area, like we would if it was any other injury. We also offer the use of kinesiotape application techniques that we can teach parents to do at home, which are very effective. We use binders and pressure regulation support. We do breathing and mindfulness exercises. Again, parent and child education is the whole mainstay of it. We use whole body vibration to work on reflexes and sensory training. We can do interferential electrical stimulation for slow transit constipation, as well as some other things. We create and use social stories to do developmental engagement with the child. And then we also do adaptation of toilet training for children with special needs. For occupational therapy, we again provide regulation support through the sensory intervention. We do step-by-step lessons through the interoception curriculum. And then we offer ADL training, ADL standing for activities of daily living, for toileting related tasks. And again, what's really makes this important, what's different than going to an adult practice who won't see children anyway, is that we do play-based, developmentally appropriate therapy for each of our disciplines.
So now a little bit about what GI psychology as a practice looks like and how we contribute to the treatment of these kiddos who are experiencing encopresis. So GI psychology is actually 100% telehealth. We offer remote services by video. Typically, we'll see ages 6 to adult, with some exceptions a little bit lower in the age range, especially for kiddos and families who are experiencing constipation and encopresis. We may go a little bit lower just because there's such a heavy family component, parent management component to it. Our practice does provide services across the country. Our providers are licensed or eligible to provide services in every state across the country. We've also partnered with GI On Demand through the ACG as well. You can find more information at gipsychology.com. But we do offer family therapy, individual therapy, and also some groups are becoming available. And we'll talk about that partnership with Good Beginnings, offering a parent education and support group that we're starting to roll out for management of constipation and encopresis as well. So what we typically will contribute to treatment for these children, by the time that they get to us, usually they're already on a medication regimen. Maybe they've already met with PT and OT. And so we're helping the parents and children, the caregivers and children, to work together and support children to make toileting and bowel movements a less aversive and more of a positive experience. Typically, that will involve development of some type of incentive system, maybe a sticker chart or some type of incentive system where children are actually getting positive feedback whenever they're able to complete different tasks, whether it's wiping themselves after having a soiling accident, or if they're able to help get a new pull-up or new underwear, whatever it might be. We also want to develop positive experiences with push practice, or if there are recommendations coming from physical therapy to help with the expulsion of the stool, we're going to work together with the family to create ways to support the child through that. Same thing would go with any dietary recommendations. If the dietitian is recommending increasing fiber in the diet, how can we work with the family to make that happen? Or if the pediatrician or GI provider is making recommendations for Xlax or Miralax or any other type of medication, we want to work with the family to create ways to support the child through complying with those recommendations, which can be challenging at times. We also will work with the family to track bowel movements. Like Amy had mentioned that beautiful Bristol stool chart before. We're going to work with families to track every bowel movement, every episode of encopresis, what was the volume, what was the Bristol number of that stool, whatever it might have been. And we also will support the family in creating what we call a structured sit schedule. Typically that'll look like having the child sit on the toilet for anywhere from 5 to 10 minutes, typically however old they are, that's how many minutes they'll sit on the toilet, and engage what we would call push practice, where they're taking time to try to expel the stool. That usually occurs about 15 minutes after mealtime. So we would have the child sit and try to push for about 15 minutes after eating breakfast, lunch, and dinner. And part of that is because of the signals between the brain and the gut. The stomach says, I'm starting to fill up with food, sends a message to the brain that says we better clear out some space. And that is a time that kids can be productive with expelling stool from their body. One other thing that we'll do as psychologists and mental health providers is support the children through any comorbid psychosocial concerns. Oftentimes, kids are coming in with anxiety about having a bowel movement, like that case I referred to before. She was just so scared to poop. Maybe there might be teasing or some low self-concept because of the encopresis. Really, whatever is going on for these kids, we want to help support them, and again, make toileting a more positive experience.
We have a team approach that we've developed with our friends at GI Psychology. We're so grateful to have found each other. And it's really been helping, where we'll start with typically that the family has found our clinic and would like therapeutic support. So they'll complete the evaluation at Good Beginnings. Recommendations are made for treatment, whether it's PT, OT first, medical screening, if there's other flags that we need. And then the family has to complete at least a single follow-up session to make sure that they're really engaging with care. And then we'll refer them to the enrollment in the 4-week parent group that GI Psychology offers. And it's a rolling enrollment. So as it's building right now, the dream is that just every 4 weeks, there's a new group of people who can get started and potentially repeat if necessary as part of their ongoing work. After completion of the group, GB as Good Beginnings and GI Psychology as a team can consult to discuss the next steps. How are the family doing? Do they maybe need some individual and family therapy? Can they repeat the group again? Or can they take a break and see how that goes? And then treatment in the Good Beginnings program continues until the goals are met or other disciplines are needed to achieve goals. We always tell families to expect that I'm going to know them for a year, because by the time cleanouts are started and the tissue starts to heal and the strength gets better and you have to work on all the different systems, you may not know them in the traditional format of every week of therapy for a year, but we let them understand that it's a longer process, but there's some intense bursts and then less intense bursts and more intense bursts until they achieve their goals. And then they're always welcome to come back for an annual well check just to keep on top of things. Did I skip a slide? No, I did not. Okay. So when do you refer? Like the goal of this talk is for Kim and I to get out there and let everybody know that these services are available, but it's not always right at the right time for every child. And so when talking about a child to be ready for PT, our referral criteria is that they're having encopresis at age 4 or older. And that just goes with all of the Rome criteria and the International Continence Children's Society standards that bowel training should be achieved by 4. If it hasn't been achieved earlier than 4, you're not behind, you're just not ahead. So when you're starting to have leakage at 4 and older, we can start. But if there's withholding at any age, true withholding, not playful, I'm in the middle of toilet training, messing around kind of things, but even infants, when they're withholding or really constipated at any age, get them started, because we can do some simple things early on that can prevent it from being a bigger problem. I once met an infant who was pooping like once every 12 days, an older infant just starting to walk, and they couldn't figure out what to do. And we did 2 sessions, an evaluation and a follow-up session with a lot of home programming. I ran into the mom a year later at a child's group, and she said she started pooping 2 times a day within 5 days, and I've never had a problem since. And that's all it took to make a difference for that child, so they didn't have to become encopretic. When to not refer to PT is when typically developing children are just getting started on toilet training without any of the other issues. So between 2 and 4 is a wide window of when kids are ready to start toilet training, and your child may be on the earlier or the later end. So if there's no other mitigating factors or no special needs, then we need to let them go through the system and help the kids who are already meeting criteria before we see if there's something else that needs to happen. We do follow the Rome 4 criteria for functional constipation for ages 4 to 18 years of age. I have a link for you down there. But the general is at least 1 episode of functional incontinence per week with a history of excessive fecal retention and or painful or hard bowel movements and or presence of large fecal mass in the rectum and or history of large diameter stools, and 2 or 4 bowel movements per week. And then go ahead, Kim.
All right. So for GI psychology, again, with this particular age range, we put the emphasis on family treatment. We do offer individual services as well, but we find for kids below age 8 who are experiencing constipation and encopresis, it really is a family treatment that's most effective. So when to refer to psychology, very similar to Amy, where we're seeing that encopresis for children ages 4 and older who are demonstrating withholding or possibly that fear of passing bowel movements. When to not refer to psychology, when we're thinking about the groups in particular, really any family is welcome. That being said, if there are significant developmental delays, if there's autism spectrum disorder, we find that families are less likely to benefit from the group intervention, and they're more likely to benefit if we have more of that individual family focused intervention. That way we can really meet the children where they are and make sure that their developmental needs are met. One other thing that we'll note is that psychology is typically not used for general toilet training. Sometimes we'll have families call in when children are ages, 2 or 3. They're expecting their child to have gainful bowel and bladder control. And like Amy said, they're not behind. It's just not their time yet, and that's okay. We don't want to make toileting aversive or traumatic, and so we will typically wait before offering support until they're a bit older.
We're getting towards the end. Thanks for hanging in there with us. How do you refer if you don't already know us? We've got our contact information here. Typically, families can direct refer themselves. We have direct access in all of our states to Good Beginnings through either looking at our website. We've got our primary scheduling team up there, or there's an information email that goes straight to my schedule team that can take care of things for me. When it comes to the group that they do at Kim's place, we automatically refer them straight to the team there so that they can get started. So they'll be automatically referred there. One note is you can't refer to the group unless you're in Good Beginnings physical and occupational therapy, because while we know that there are people at other treatment centers or things like that, we just don't know how the programs overlap and if we all share the same information. And we would hate for a family to come to the group and not be prepared for it because their program looks or does things differently. So right now, this is our special for Good Beginnings people, but not too hard considering there's not too many people treating around the area. And then we love if we can coordinate with the physicians, faxing notes or records to our fax number below, 703-536-5677. All information is appreciated. I have my email out there. Please go ahead and take it, amio@gbtherapy.org. I love to talk to the doctors and really work together. And then Kim has the email linkage for GI psychology, so you can refer for individual treatment. Families just go straight to the website and start their intake online. It's a really smooth system. And again, anytime you want to talk to us, please feel free to. But you can just give families our information and get them started that way. And then we wanted to say thank you. We definitely have time to address questions. And again, one more slide with all of our emails that you can reach us at. And again, we thank you for your time today. And we look really forward to collaborating with you on these patients so that we can get them relief much quicker and hopefully decrease the kind of epidemic of constipation and encopresis that we're seeing currently.
Thank you.